And that's why we had this huge program of workplace testing, and we had tested many CEOs. We used to call it CEO testing. And we had even tested Obama when he came, and that was like the beginning of that whole process. So the gap was that we also had some facilities where we're offering care and treatment. And the donor had insisted, now you must have a medic to lead the care and treatment arm. That's how the position of care and treatment manager had come up. So that is what we had interviewed in March. So it later turned out that the person who was hired in March was then promoted to director of services at that time. So the position became vacant again very quickly.
Welcome back to a continuing conversation as we document the story of Dr. Lilian Otiso. And so far we've heard about your roots from birth, from Kisii to Nairobi, the school, to different schools in Nairobi, and then all the way to you becoming a medical officer and experiencing a lot of that in what was previously the Rift Valley province. At this stage, you had been called for an interview at you had applied for a role at LVCT Health. They hadn't called you, so you went to AAR. How did that all turn?
Yeah, so actually I had been called for the interview, even interviewed. I thought it went pretty well.
First round.
Yeah. But that was around March, March. But they didn't call. So when now I interviewed subsequently, they moved there and worked there for the 2 months. Learned my lessons, very clear what I should and should not do as a career. As I mentioned, just being clear that in a private sector, direct service delivery was not my thing. But it also started showing me the management bits and how I liked that, even if it was very minor. So when I moved to LVCT, they called, and the position was care and treatment manager. So LVCT was an NGO, and most people know it as Liverpool. Yes, VCT, and Liverpool VCT Care and Treatment, and was really credited with starting the VCTs in country, and started as a research project actually from a PhD student from Liverpool, hence the name. So in that aspect of, I came in, so they had done very well with the testing, prevention bits, but were not doing so well in care and treatment.
They were only like 3 or so years old at the time.
No, by the time I joined in 2008, LVCT had been registered in 2002.
Oh, wow.
And the PhD project had started around 97, 98.
Okay.
Yeah, so 98 to 2001 was the PhD project to set up VCT centers in country.
Right.
And that was very successful. So government said, we like this model, we need to scale it up. So that's why the NGO was registered with support from Liverpool School of Tropical Medicine. Who sent in the first director to really help to set up, establish systems, make sure it's registered, have a board, all those things. And so when I came in, basically it was 6 years into the organization, and it was going through an expansion. I had received funding from CDC. Most of it was HIV testing and even training the VCT counselors, as they were called. Now we call them HIV testing services counselors. So we even had funding for that training and all. So the gap was that we also had some facilities where we're offering care and treatment. And the donor had insisted, now you must have a medic to lead the care and treatment arm. That's how the position of care and treatment manager had come up. So that is what we had interviewed in March. So it later turned out that the person who was hired in March was then promoted to director of services at that time. So the position became vacant again very quickly.
That was very quick,
And so that's how I came in. And so I came in to run the care and treatment portfolio, which was now those clinics.
It was national?
It was in Kitui mainly and Nairobi. We had a clinic in Nairobi, Riruta, and Kitui, where we had a number of facilities. And so again, back to my traveling days of going to Kitui, I keep telling people, I know Kitui, those backwaters people don't know. Mutomo, Ikutha, Ikanga.
Oh, I have no clue.
Yes. We used to go there.
And it's interior.
There were no tarmac roads.
Oh.
Yeah. But I have watched this country just improve. It's fun. It's significant. It's fantastic. Yeah. Because most of the time you would go to districts which have no tarmac at all, or 1 kilometer of tarmac up to the town. After that, nothing. But now you go. I remember we went to Homa Bay in one of those projects, Suba, Bita. We had to take a ferry. We had to go through, get stuck in the mud. Right now, I can't even recognize. I mean, it's all tarmac road, very nice tarmac. So that was now
that's
my experience then. So we started with those clinics, and then through that job, I came and found a team already working, and I had to take over and coordinate them, manage the team, work with the donor to understand what we're supposed to do with the project, how do we make sure it's delivered, and work with my counterparts who are doing the HIV testing, which was also in the same areas, and also had some in Western Kenya. So I quickly just got into it. I loved it.
The rhythm was not unfamiliar.
No, it was going to work in government facilities or to support government facilities, which I was very familiar with. I mean, that's what I had basically come from doing. And doing the supportive supervision, which I had learned, understanding government systems and how do you get things to move from this to this? How do you introduce a new concept to people and get them to buy into it? So
I'd like to draw into that, but also supportive supervision. When you talk about supportive supervision, this is largely to the counselors themselves, or even to your own staff who are on the ground?
Yeah, so for my staff, it's more of mentorship and support, and then to the facilities we are visiting, the health workers there, counselors, clinicians, records officers, lab techs. It's what we call supportive supervision, is where we go in and we look at this is what you're supposed to achieve, how are you achieving it, what are the gaps, and how can we address them together, and providing mentorship and coaching for them to improve. So actually sitting down, you, even if you see have to see patients together, you'll see patients together. That helps you. You go through the tool. This is how you enter the tool. But then some of the things you learn from that is that this tool is ridiculous. Where are we?
It is unnecessarily long, and it is calling for data that's probably not so useful.
It's not available, it's not useful, and it's tedious and takes so much time. So being on the ground for me is one of the most critical lessons I've learned with any work, any job you do. You better know what people are actually doing, what they're going through, before you come up with like your lofty ideas and policies. So that helped me a lot. So we would sit, go through it, work with my team. And then my most important role was, because I had a team that was the one which was going to do that visit at the facility, that supportive supervision, I would teach them or work with them to show them, to understand how MOH works and how to respect those facilities and to respect the health workers there. They know their staff. You're just in a different, you're just employed by someone different. But it's not that they're stupid. It's not that they don't know what they're doing. They know what they're doing. So you're only going to support because you're introducing a new concept, which is adding to their work. And so you have to be embedded with them. And because of that, so as the portfolio grew for the care and treatment, we got a grant to do provider-initiated testing and counseling. It was a new concept in the country globally, where now, instead of waiting for people to walk into VCT, you offer HIV testing.
Where they are.
Yes, or you come to a facility, I offer you. Whether you wanted to do a test or not, if you're in the facility, you're catchment. Very good. And it's actually continued. It's one of the, with what has been happening with testing is we've been changing and adapting to more efficient methods that will give us better results in terms of, you don't want to test 1,000 people and find no positive person. That's a waste. So it's how do you test fewer people and identify the positive, because it's important we find those positive and put them on treatment. Because right now we've seen with the treatment, the lifespan is almost the same as everybody else. And that's the priority. So that was the idea of provider-initiated testing and counseling. So go to the outpatient department, set up testing centers or booths there or rooms where a clinician sees a patient, refers them there, they test, go back.
Would there be like a criteria to try get the more positive ones?
So only in terms of just because of limitations in human abilities and resources, yes. So we would prioritize ward. Any inpatients would be tested because by the time you're admitted, you are very sick, so we need to test you, and we had a higher positivity within the inpatient. TB clinic for sure, because the
Definitely.
TB HIV link has been demonstrated over and over. So we would test there. If there was anyone with an STI, definitely. But that model was what we call diagnostic testing and counseling, which was kind of targeted. But we moved from that to now saying broader, provider initiated. So everyone is eligible to be tested, as long as you've walked into a hospital.
Right.
But you can opt out. It was not compulsory. You can say, I don't need to. With time, we refined and said, okay, if you are just tested in the last 6 months or 12 months and you've not had any sexual contact, you may not need to be tested. But the PITC yield really helped and has continued up to now. So what has shifted more recently is that we're still doing it, but now we have a screening to screen out those who really don't need a test. Again, as I said, if you've not been exposed, it's very quick. It's just done by the counselors themselves. If you've not been exposed, why are we testing you? Because also the resources are limited. The test kits now are even limited.
Were there particular key demographics that would the numbers would be higher?
Yes. So for sure, as I mentioned, outside, so there are those disease areas like TB patients for sure. And then now we had what the population, which was called most at risk population then, currently called key populations. Those who are, we talk about sex workers, both male and female. We talk about men who have sex with men. We also have injecting drug users. They are at a higher risk of HIV. So those would have a higher positivity. And most of the time, those were not found through provider initiated. That's us going to the community, coming up with innovative models, working through their peers, moonlight, where people would go and test from 4 to midnight, wherever the communities are, and work with their peers to make sure that they're the ones who mobilize, and we just test and then offer them treatment services which are specific to them in their own what are called drop-in centers.
What are the challenges for that came with that role and that particular model?
So LVCT has been a pioneer in doing that. I think that's something which I even found there when I joined, and it's an interest. It's very tough. It's not easy because first, those are marginalized and criminalized populations. All three are actually criminalized in Kenya. So they would, operating in shadows, meaning that you're going to offer testing at night in what may be called dangerous places, and we're sending our staff there. So those risks definitely are there. And we have actually our vehicle, when we went to a drug den once, the vehicle's windscreen was broken by the community. They were chasing us.
Because you're coming to sort of promote, they would think.
No, it was the drug users themselves who, before we got rapport and they accepted us.
Wow.
Someone stoned the vehicles. They're like, oh God. We've had staff whose phones have been stolen, things like that when they've gone to, now not even those communities, but we go to informal settlements. We've done home-based testing, like door-to-door in Kawangware. We did in, there's a place called Raila. There's a place, very many slums in Nairobi. Those are not safe places. But we did it because we believe that really we have to reach those who need the services, must be reached. Then for the key population themselves, it's even just acceptance by the community. Why are you offering this? Why are you coming to do this? Why is it not? Why are you targeting us? So a lot of it has been engaging with them, recruiting people who are actually from those communities to lead or to do or implement those programs. That has been quite instrumental for us to move on. Over the years, we were very deliberate as an institution to build the capacity of smaller organizations, local smaller organizations for those vulnerable and marginalized groups. So all those groups, female sex workers, men who have sex with men, drug users, and also young people. Grow them and allow them to do those programs with funding. Initially, you pay for all the services. Then we build their capacity until we can even give them a grant to run it themselves. And that has been quite successful for them to run their own drop-in centers and to implement the projects or to be the ones who mobilize so that people can come to facilities. And we've also worked to ensure that the services are offered, whether in the drop-in center or in government facilities, because we can't be everywhere and you can't set up standalone. But the risk of HIV, the risk of STI is very high in those groups, and even things like hepatitis when you think about the drug users. So our goal is very clear. It's about health rights and how do we make sure that everyone is able to access the services they require when they require them and to the standards that they require without discrimination and stigma associated.
And affordably.
And affordably, for free. All these things have been free over the years, but that is because we've been funded. Although the funding is declining, and we now have to keep thinking of innovative models and ways
of revenue.
Yeah.
Back to so you come in, you're growing the program. There's initially you found a CDC program. They start expanding to a few more funders, but you're also integrating quite a bit with the testing colleagues that you have. How does that, in your early years, how does that go?
So first, I cannot work in a silo. As an individual, I can't. I have to. For me, it makes sense that you can't do care and treatment if you're not doing the testing and seeing how that. Thinker. Yes, I'm a completely systems thinker and solution oriented. So we were able to then keep growing. That's all I learned. I learned how to do care and treatment. I learned how to do testing. I learned how to do or manage. Let me say manage. The other thing that came about was gender-based violence or post-rape care. We had started as an organization, post-rape care services. From when the VCT centers were set up, what started coming through is people who were raped were coming to report in VCT centers that they were raped and they didn't know what to do. And that informed a study, which was actually a PhD project for a former director. And from that, we're able to establish post-rape care services in country and get them into policy so that we're able to have a curriculum to train health workers, train VCT counselors. So it was a matter of basically what services, what to do if someone comes and tells you they were raped. And that was the beginning of that. So we grew that, and that became also my responsibility as care and treatment manager to make sure that we scale that up to government facility. Again, the same approach. Who do you talk to? When you go to a district, first of all, if you're going, you have to talk to people at national government level, provincial level, and the facility, and get people to buy in. Organize the trainings, decide how you're training, the trainers of trainers, and then how they're cascading that. And we helped to set up some one-stop shops for GBV. We actually helped to set up the one in Kenyatta Hospital, in Kisumu, GTRH right now, where we helped to set that up together with KEMRI, with funding from CDC, and we also helped in Nyeri and Nakuru. Besides that, it was now making sure that the facilities we worked with were trained. At least you have one or two staff who are trained that they know what to do if someone is raped.
And you're thinking of this integrated, not necessarily just GBV. So it's capacity. You can do. At times, the patient will come in not because they'll come in maybe for a HIV test, but then you discover there's more. Or they'll come in with GBV, but they have all these other issues. So how do you provide that? But we had to be very clear to develop protocols and algorithms that people can use. If someone is raped, what are the first things you do? First of all, how are they treated? How are you conscious that you have to be sensitive? Because people would complain that they go to the facility, who do they go and tell? Do they just wait in line? So talking to the facility to have a place where someone like that can report and get express services. Linking with the police, very important bit. And most of the time in health, we just think health, we are very siloed. So partnering with the police, the different facilities, our staff were involved in setting up like court users committees, either establishing or joining others that already existed, which brought the police, the magistrates, the chiefs, and the health workers. Lawmakers and
because this is one case which is not health only. For us, we focused on the medical services someone needs immediately, like making sure that you treat whatever injuries, you give post-exposure prophylaxis for HIV, you prevent pregnancy if possible through emergency contraception, you treat if there are any STIs. So we would do all that as an emergency. And then also, and this was another important bit that we did, was developing what is the forensic, what is required, the chain of evidence. So we did a study on chain of evidence. And how does a health worker collect that? What is the basic what can a basic kit look like if you want to collect that evidence, and how can we provide it? Because before, when you read the literature in other countries, there were very fancy kits for collecting, which we are resource limited.
Yeah.
So trying to develop a kit for resource limited settings. So scaling that up, that has been the journey on GBV. So that's how I moved from managing care and treatment to the testing.
Managing a bigger portfolio. and also now introducing GBV. LVCT is as known for HIV as it is now for GBV. I don't think there are as many organizations that have that holistic dimension.
No, most people specialize. But for us, it's, again, that thinking of a patient is holistic. And in a health facility, how can we add all these things? So that's how I scaled it up, or now took over the management of the GBV bit itself. And
at that time, is the portfolio still care and treatment, or has it grown to services?
So I was care and treatment manager for 2 years. Then the person who was the director of services left. So I took that up within 2 years. And so what happened is, what I was doing alone, I had to hire 3 people to come
GBV,
in. Yes.
Lead care and treatment.
Yes, and the PITC. Yeah, because we had also got more funding to scale up a lot
those
more
programs.
Yeah. So that's how now I was like, okay, good, we've grown. Continue to do that.
Talk to me about your leadership journey from now, because here you've entered LVCT as a manager and you're leading people, and quick enough after 2 years you have to lead people who are leading people. How is all that happening for your psyche, and as you grow more and more into management? What tips, tricks are you seeing are necessary at that time? Do you go for like management training to refine a bit of this?
Well, I think, I don't know, it just kind of happened organically that I grew, and what I would do naturally. First of all, I've always been that kind of person. It's truly open door policy. That's the LVCT way. And I practice that, and I'm happy to discuss with anyone, brainstorm, come up with solutions. So through that, even as care and treatment manager, I was already like overseeing or supporting a lot of people in their different ways. And my natural ability to find solutions and help people to come up with solutions was, I think, one of the most critical factors, and being a very good listener. So I listen and try and understand people. The other thing that came is, of course, there was mentorship and role modeling. So I learned a lot from Duko, who was our executive director then, in terms of certain things about leadership. How do you make sure things are done? Delegation and follow-up. That was a big challenge, by the way. Delegation was a big challenge because I could do many things. So it's very hard to let go. Or trust people to do them. And so I would be leading them, but it would be very hand-holding type, doing a lot for them. But also the thing I learned is you hire smart people. So when I hired sharp people, there are things which just moved naturally. Like I didn't have to.
Comfortable.
Yes, you just feel comfortable to let go. And now you focus on the ones where you feel like, okay, this person is not so strong. I also believe in challenging people and recognizing their strengths. And I remember reading an article that was talking about strengths-based leadership. And it specifically said, I think it was even GE or somewhere, and they said, what someone learned is that people have strengths and weaknesses. Don't bother with the weaknesses. Don't try to train the weaknesses out of someone.
Yeah,
magnify and strengthen and build on their strengths. Those weaknesses, take them and give it to someone else's when someone's weakness is someone else's strength.
That's true.
So reassign roles with that in mind. So in my mind, a role is dynamic. I may hire you today for a role, and you come and I'm like, well, the role was these 10 things. You can do 6 very well. These 4, you're terrible. I will not focus on those 4. I'll probably find someone else to do those 4 and give you others from someone else. So that has been one of my, I think that's really...
And you have to, this has got to be constant, because also individuals are evolving.
Yes. And depends on people's interests. Like, there's a time now the care and treatment portfolio grew to include care and treatment and GBV. Even now, after I'd taken over, it was care and treatment and GBV. And then the person grew. So it became a matter of who do we come to replace? And the person I could get for care and treatment could not do GBV at all. So I was like, I cannot assign the person the same portfolio that the care and treatment manager had, because they'll fail, and the GBV will fail. So if this other person is still passionate about it, then she can do whatever she's moved to plus the GBV, because it's a passion. And this other person will do care and treatment and whatever else I see fit for them, without thinking of semantics that no, that job includes this. No. Jobs are dynamic. They change. They shift.
And therefore even maybe the organizational structure.
Yes. So we can't be fixed and say this is how we are structured. No. We have to keep thinking about it and moving people around and challenging people to try certain things and investing in growing people based on what they're able to do. So those are, for me, key lessons. And
at that time, is there any area you feel you yourself, you are probably not as good at? You are like this, you are excited about something and maybe not something else that the role comes with.
Yeah. I've been spending my journey thinking about exactly that. Like, what am I good at? What do I like doing? And what don't I like? So for example, with time, I've moved on from doing HIV hardcore,
the technical aspects,
and I'm okay.
Which you 10 or so years ago, when you were entering, those were primary.
Yes, but I even discovered even that time that even for the HIV, I was more interested in the systems bit. How do we make sure patients get in, get treated, go? I wasn't so invested in this is the latest treatment. These are the latest drugs we need to use. I've never been fascinated by that hardcore, pure HIV science. It's more of the systems bit. How do we get more people in? How do we achieve results? If you're saying we need to achieve 90, what are the bottlenecks to achieving that, and what can we do? What can be our contribution? I remember thinking when people brought in 90, I was like, guys, it's very easy to do care and treatment, because care and treatment is someone has already been brought to you. You just have to offer them treatment. The drug exists. A nurse can do it. A clinical officer can do it. You don't need a doctor to do it. And then you just follow up. So it's very regimented and clear.
But the last 90 is hard because that's around retention.
It's still easier than the first 90.
Oh, the testing.
Yes. So it was thinking, and now going to the table and saying, guys, we must not forget, because most people neglect the first 90, the prevention bits of HIV. They are community.
Those are behavioral.
They're community things. Doctors don't get that.
And
doctors are all, there's a pill. Take a pill and you'll be fine. And then now the behavioral bit is, how do I make sure you keep coming back? That's it's not easy, but it's relatively easy compared to going to the community and convincing everyone to test.
Men, women, young people.
Yes, and knowing where to go. And here you are, the donor is saying your targets, you're not achieving.
You have to have a higher yield in a particular place.
Yes. So constantly strategizing about that was a big challenge. So for me, that was very fascinating. And I would enjoy visiting the sites, talking to staff. And I remember one model we came up with, which became even revolutionary in the country, was what is called partner notification services. I know people keep complaining about it sometimes, but the truth is,
the privacy around it is where you notify my partner.
Yes, and we were clear that we were not notifying without consent. It came through where one of our staff in their site, she just said, someone came and I asked them to bring the partner, and I followed them to the community and I tested them with their partner there and all. And then I found that they had a partner here, they had a relationship with so and so.
The Nairobi song.
Yes. So we ended up writing that network. And actually there's a case where we found one person was responsible for 64 HIV positive cases. Yes.
Oh, because of that partner network.
Yes. So this one person had a number of like 5 sexual partners, and those 5 of course had
others. 64.
And some people were tested positive, some people tested negative. So we followed them up. So
which is also for many people a wonder. Is it, or how can there be contact with someone who is HIV positive and not test positive?
Yeah. HIV, fortunately, is not like Ebola where you just touch and you get it. It's you don't get it at first contact. No, you may
get it at
but
first
you
contact.
may, but it's not a must. It's not a very infectious in terms of 95% infectiousness, and it depends. If someone has an STI, then the risks of getting infected are high. But if someone's is not having an STI, then it is the more contact they have, the more sexual contact they have, that predisposes them. But it's not always that the first time. Right now, we've seen the evidence has shown that if the HIV positive person has been taking their ARVs and is virally suppressed, meaning it cannot be detected by the lab test, then their chances of infecting their partners or their unborn children are almost zero. It's what we're calling U equals U, and undetectable equals untransmissible. You cannot transmit. So it's one of the key strategies we're doing, which is why we want to find HIV positive people, give them treatment, because it benefits them, because they'll also be able to live normal lives, and it benefits their partners and their babies. So that's why not everyone, just because you've had contact with HIV person, positive person, will get HIV. So, but if you have some multiple contacts, multiple exposure, you have other underlying conditions, then you're likely to get it.
I think your work then was exciting because of the system, just thinking through this whole system and network and figuring out with your staff how all of it could play, as you are also enjoying mentoring and enjoying supportive supervision. You didn't take long before you became before you got a promotion. So I did that that was 2010. So in 2014 we did a different restructuring, and I voluntarily took up more roles, because by then the executive director had gone, and the former research and policy director was promoted to executive director. So we ended up having a gap in research and policy work. And so, being who I am, I took it up, because now and not coming from that background of research. No,
but I had started doing research a bit. There's a time when there was a study that was proposed in 2011, 2012, which involved communities. And the director said, Lilian, I think you should try this. I think you're a health systems person. You go try this. And I participated in that. I was involved from the proposal writing. It was a huge grant, EU funded, led by Liverpool School of Tropical Medicine. So it's those kinds where you even bring all the partners together to write the proposal, because it was going to be £7 million or something like that. And so I went to Liverpool to write the proposal with people from different countries, who were about 7 countries and all. And I remember sitting in that room and saying, everybody here has a PhD.
Wow.
And they are, hardcore researchers, and they know their stuff. So I was like, what am I doing here? I think I'm in the wrong, properly. So I sat there, and then I'm reading what has been written, and I can't understand. I remember telling myself, maybe now I'm in over my head. Oh, just retracing back to LVCT, when I first joined, I attended the monthly review meetings we have in
the
5.
management meetings,
Yes. And things were being presented, and I was like, why am I floating? I don't understand. Am I dumb or what? And then with time I said, don't worry. So I started getting it. And then I remember also attending a meeting with the executive director, and she was a hardcore researcher, high level things. So I remember thinking, wow, am I that dumb? As in, I really can't understand what is being said. And then I discovered, it's not me. Everyone
in the team
is struggling. So it's not just me. And then I discovered my strength. My strength was, now with time, I started understanding what she's saying, and I became the one who's translating it to everyone else.
Taking this large elephant but chopping it into pieces.
And explaining to everyone. So Paul would come to me, what was she saying? And I would then break it down. So that has been my thing.
It has been interesting because LVCT, given the leadership at the time, actually given its journey, as you explained, from a place of like research, the leadership that was in it throughout were doctors, but these are PhD doctors. And I guess that's why it would sound for many people who are now there for other technical pieces, maybe it would sound a little too strange.
Yeah, and especially social science.
Yeah.
It's kind of social scientists have a lot of jargon.
Yeah.
Yeah.
which is interesting.
Yeah. And make things sound very complex. So yeah, I think medics like to simplify things. So
when you took over research, rather you volunteered yourself for research. You said research and policy. The leadership was still again PhD.
Yeah.
How was your journey there? Was that something easy to pick on?
So surprisingly, it wasn't as hard as I thought it would be, because the same principles apply. I'm not necessarily coming as a technical researcher. I'm just the one who's making sure that things move and people are able to do their job and they understand what they need to do, and you're the expert. Do your thing. I will help you with looking at the budgets, looking at staffing, strategizing, and all that. So it wasn't as difficult as I thought it would be. And as I said, I'd started engaging in research. So I was involved in this big study called Reach Out, which has really influenced community health work even in Kenya. Yeah, so, and after I discovered, okay, I've sat here with all these clever people, somehow I have something to say. I discovered that, yes, they might know research methods, but they don't know the ground. They don't know. And
that's your strength.
That's my strength. So I started leaning into my strength, that what you're proposing would not work. Therefore, I am proposing this because first, this is how the local setting is. This is how you have to work with the ministry. This is how you have to consider the communities. And that is actually a key asset that research needs, especially when you're doing implementation research, when you're not just going to do lab work. You need people who understand the ground. So that was my strength. And then with time now, I got to engage more, understand the methodology, participate in trainings, different workshops, different conferences. So I gathered the confidence to know that, yes, I can.
You are a researcher.
Yeah, I can support research. So I was able to then manage that and still focusing on, I am not the master of all these things. I don't know.
Because now that's a larger portfolio. Yes. Because it's not like you let go of care and treatment. Yes, you had. It all became part of what was under you.
Yes.
So you're like leading 5 different units.
Many. Yes.
Many. Including youth and key populations and policy and others.
But that's why you hire good people and let them do their job and let them do well and understand where's your North Star, where are you heading, where do you want this program to head, and that's what I would help people to do. So let's say, for example, the youth program, it's having a conversation, a brainstorming meeting, where do you see it going? So working with them to do that. And I worked closely with the executive director, and she was still assisting with the research, even that thing of policy and strategizing. So we would then help to brainstorm and think. And now my job became following up. What help do you guys need? How can I work with you to make sure that you're aligned? And also making sure that people become experts in their own fields. So if you're coming in to do GBV, how do you become the expert? If there's a meeting in Geneva, it's not me going, I don't know GBV detail. You will go and you will represent and you will grow. And that has always been an LVCT thing. You go for meetings, you make sure that you really represent the organization well. You have to be known and have some substance and come and feedback to see how it will help the organization. So that was my approach. And through all that time, then we got a lot more. We started getting more grants. We got, we had 2 CDC grants, large ones that we had to implement. They were the first large ones that took us to double-digit figures. And then, and all these other 2 small grants. So a lot of my time was actually managing those grants and making sure that we are meeting.
Each connects to
and we're meeting whatever the donors want. I like to pride myself that for LVCT, we get things done. If you tell us to do this, we shall do it. And it's because, first, whatever we recommend can be done.
It's evidence-based.
Yes, it's evidence-based. We have experience. We have very good networks and relationships on the ground, which get things done. So we deliver consistently. And we're responsive. Of course, sometimes we have failed. We've listened to feedback and we've worked hard, and that has been my job. Like, okay, guys, this one we failed. Where did we go wrong? What do we do? And then we set a path and the teams work on it, and I'll follow up and support them to do that. So that's how I manage that portfolio. Again, growing it and growing teams there. I also really believe in growing people from internally
inside,
to grow to new positions and only hire when we must. So that has helped a lot of people who even started as interns to really grow to managers. Position.
That's beautiful. The research, policy, practice model is one that LVCT that time and maybe continues to up until this time really hold dear. Would you see some of the research work that you are doing begin to inform not just the programs that LVCT is doing, but also policy at national level?
Definitely. We've said that for years now, and we believe in it. So we call it the RPP model or the research policy practice. So we don't do research for the sake of doing research. We do it to answer questions or address gaps that we are seeing from our implementation or that have come through from our engagement at national or at the different levels. So starting with the example of GBV that we had talked about, it was that people are coming to VCT centers asking questions. So that became a research study that then moved on to you end up formulating guidelines that are based on the evidence you have gathered and evidence from other places. And you develop training curricula for staff to use, materials, posters, supporting things that are going to help health workers be able to implement that. And so it did inform the national policy and informed the practice at facility level and different partners. And we've continued up to now to even train implementing partners, training counties on how to do GBV just from that. And then it's always cyclical. So we started with the post-trip care services, then moved on to, as I said, chain of evidence. In fact, there were 2 studies on chain of evidence as you keep build. What is the gap, and then how do you make sure that it actually embeds and use locally available resources? Now we're doing studies on violence against children. We've done studies on intimate partner violence, and those have gone on to inform national guidelines. And how do we make sure that, and we remain focused that there are many GBV partners. We don't do everything. We've focused on, for a long time it was response. So what happens when someone is raped or undergoes violence? What does a health worker do? But now we're also looking at prevention and how do we address that? And we are partnering with people who are doing the legal work, the police work, because we can't do everything. So we have to, and we really believe in partnerships and work in partnership.
Strategy.
Yes. So whether through the research or the programs itself, the practice itself, when we sit at the policy table, it's all stakeholders and we put all these thoughts together and inform policy.
Which you did quite a lot of back then when you were still new, like just setting up stakeholder groups, technical working groups. Which are a few of the ones that you particularly got involved in that have a result that you can say, I helped influence this?
For sure, like the provider-initiated testing and counseling, we helped to come up with the guidelines that were rolled out in the country based on our lessons. The GBV work, the post-rape care work, I was involved in that. I've been recently involved in community health. There's a community health quality improvement strategy or approach that we came up with through research and tested. Can you take these very complex concepts of cure and quality improvement and telling community health workers, can you do your plan, do, study, act, that kind of thing. So we took those complex ideas and worked with community health workers and community members to implement them through community work improvement teams. And we came up with a manual which has now been taken up nationally. And actually, government has been scaling it up through. They found resources and have been scaling it up. We've been supporting in different ways.
That's a thing to be proud about.
I'm very happy about that. And actually, even right now, we're playing a key part in the community strategy. They've rolled out the electronic community health information system, ICHIS. So we are doing a research study, a trial to test how there was no linkage between the community and the facility data systems. So we've developed that system, that linkage module, and we want to test if having that improves antenatal care outcomes. We're testing that in Homa Bay at the moment. And we already know that regardless of the results of the study, that module was a gap. that government, where we worked with government structures, just supporting them to develop that. So we know it's something that will already scale up just from that idea.
I could listen to that aspect more and more because it's very intriguing. But I also want to go back to your own journey now growing into leadership. Is this the time you also decided to take an MBA?
Yes. Yeah. So I had been looking for a master's program. I'm ashamed to say I'm one of those who dropped out of my MPH program. And I can't explain why.
You had actually started?
I had started
before
around 2010. Yes. And I don't know. You know the way Kenyan universities are, things are slow, difficult. So when the MBA came, the Strathmore MBA came, how did I find out about it? A friend of ours was the manager of the program at the time and invited us for an event in Strathmore. So I found out about it and I was like, these are all the things I want to know. The course content is exactly what I want to know. And so I enrolled and I really enjoyed myself.
You thrived.
I thrived. Everything we were learning, it was a 2-year program. Modular, so we would come to class for 2 whole weeks every 2 or so months. And yeah, so I would take time off and I had a lot of leave days I was able to take, and we have study leave in the organization. So I was able to have that time off to come focus because it would be class from 7 to even 7 sometimes. So, and the class is full of other people in healthcare spaces, especially government and private sector. So it was good engaging. I loved it. I enjoyed it. I enjoyed the content. I enjoyed the case studies.
How practical they
were. It was very practical. And those lessons are still useful for me now. The networks are still useful now. In fact, we were just reflecting yesterday with a friend that, we still maintain
a lot of the relationships there.
Yeah, so that...
Was it like a first cohort?
We were the second cohort, but the first cohort was only 6 months ahead of us, so it wasn't that long. So we all graduated together.
Right.
Yeah, the first and second cohort. And they had all these visiting lecturers and also Kenyans and experts who would come to talk to us. So it was a very good program. I would recommend it. And then using the case, basically the difference between that, the MBA in healthcare management and the regular MBA is that the case studies were aligned to health.
To your work,
Yes. So those are very instrumental for me. Now, one of the benefits that came from doing that MBA was that I would take 2 weeks off where no one should disturb me. I am off, I'm unavailable, no emails, call me only if it's a serious emergency. And my colleagues took that, and one of them in particular told people, do not disturb Lilian, because I would never take time off for real. I was one of those people whose leave was fake leaves.
You're away physically, but... And
everyone is always calling me. As I said, I'm very supportive. So that support can be excessive. So that was the best immersion into delegation. And
right, because again, it's 2 weeks after every 2 months.
Yes. So for those 2 weeks, you cannot reach me. Learn how to do your job. And for me, learn how to delegate and not worry that the world is going to collapse. So
that's hard.
it really worked. And people learned. And I remember one of the lessons we had there, someone shared a story about passing the monkey. I don't know if you've heard about the monkey. Yeah. So you assume that you have a monkey on your back. That's the job that needs to be done. So when you delegate, you hand over the monkey. So I pass it to you. So what happens a lot is that the junior people you've delegated to are very good at passing the monkey back
to you.
And they'll say, I've worked on it. So someone does bare minimum and gives you the job. And then you're very thorough. So you will do.
Comment.
You're like,
you
it's so bad. It's too much work. I'll just do it myself so I can get over and done it. So you've taken their monkey. Them, they're free. They've gone on enjoying their lives. And you've taken the monkey and someone else's monkey. So you end up having
this many monkeys.
Yeah, so you're carrying a lot of monkeys that don't belong to you.
And on you as a leader, it becomes excessive weight.
Yes.
Yeah.
So that now it became clear. I even went and gave feedback to the team. I shared that story and told them I've stopped taking monkeys. So
that's very powerful.
Yeah, it was very, very useful lesson. And that still remains now. So sometimes I have to reflect and say, have I taken people's monkeys that don't belong to me, so that I don't overload myself, which I'm very capable of doing. So that delegation really came through that. That was 2014 to 2016. So I learned how to delegate, trust people. I also had to learn how to trust that people know what to do. And I learned that feedback is that I put their track changes. No, I put comments. I don't do the work.
Actual editing.
Yes. I will put track comment, then the comment so that you can learn. And I will
this is
call
what I'm
you.
trying to look for,
Yes.
but now put it in your language.
Exactly. And if there's total lack of understanding, come, let's have a conversation. This is what I expect. So one of the key challenges that remains with that and with a lot of people is you will get that document on the day of submission. Yeah. So trying to be tough that you give an earlier deadline and you stick to that deadline. Something I'm trying, not always successful, but also now with time, once you build people's capacity, then you even start trusting that they'll just do the right job.
It can go without you having to review.
Depending on the level someone has reached and how much I trust them. So that has been
those are incredible leadership lessons.
Yeah, but I've also suffered from that thing of where people send things without my review. I've also had.
Because then it's not quality, and then it probably has gone with your signature. Like you're the front face.
Or even if it's not my signature, I'm in charge.
You're still the face of the organization.
Yes. Or even that project. Hey, there's a time I had to deal with
crisis.
That and really apologizing. And now just redoing that report and using it as a lesson for the team that it can never be this standard. You know, it's so embarrassing. I've apologized 1,000 times. I'm tired of apologizing.
It was that bad.
For that one and many others. God, I have apologized. That's the other thing with leadership. You have to take the now that that monkey is yours alone. You take responsibility. You accept where you failed. You apologize on behalf of your team, and then now you go and sort out your domains within the organization and try and put systems in place to make sure it doesn't happen again.
But you take the heat on behalf of the team. If it's external heat, you take the heat.
Yes.
Then you'll come and
we'll deal. Yes.
Internally.
Yeah.
No, that's beautiful. I'm still intrigued though by the expansion. And it's good that you brought about the issue of like the breaks, though they would come, the academic breaks, and then you're letting go slowly. But then your journey doesn't stop there. It continues. You continue taking more. Was there after your master's program, at that time you were director of programs?
Yeah.
Programs is everything really that the institution is doing.
Yeah, it was literally executive director, director of programs, operations director, which is now all the finance and stuff. And I would work very closely with the finance, the operations team, because I said I love math and the finance bit. So I was basically in charge of quite a bit.
The reviews of budgets would be both from the ops side, but also on your side.
Yes.
How long did that period of director of programs last?
That was 2014 to 2019 when I became an executive director. So, but what I did when I was director of programs is, because of how big the portfolio was, also elevate some people to what were essentially director positions, but we're just calling them head of. Like you have head of research and M&D. You have a head of special projects, which is many small programs or projects doing unique things like the digital health, adolescent health, and then there was the business development, which we're now trying to develop an arm, or a sustainability arm, for now growing the financial, the non-donor funded money, and turning some of our products into commercial products.
How has that gone?
The LVCT.
No, the whole product of the whole new business, different revenue streams.
So it's grown. So anyways, I started those departments, and then now I would manage the programs from the CDC funded program. That was I had to keep doing that as a principal investigator. So that really helped me to then divide and manage those roles and responsibilities. For that private arm, so for most NGOs, for those people who don't understand NGOs, we receive money. And it is very restricted.
Marked to
it is
this
marked. Yes.
This pen, 50 of them.
Exactly. and that I've funded you to do HIV only. Please don't start telling me you want to do family planning. Yet the county is looking at you like you're the ones who have money. I have money.
And there's no way, I mean, these are integrated issues. These are intersectional issues. So,
and to me, as a systems thinker, I'm like, that same money can help this, but the donor has earmarked. So you have to be very specific. And in the HIV world, when we started, the time I joined, as I said, we used to train the city councillors with donor funding. We used to go to workplaces to identify HIV positive people. But with time, those became non-essential.
There's a huge stigma that I guess would come with that, right?
No, it worked because it's how you go in and how you sensitize people. And you provide the anonymity. It's just that now you're in the workplace. And people, human beings, love it when services are taken to them.
Yeah.
I would not work here. Like right now, every time I think of going to hospital, I just get sick because of the queuing and whatever. If you brought the services to me, I'm more likely to take them up. And as long as you assure confidentiality. So we used to do that. And that's why we had this huge program of workplace testing, and we had tested many CEOs. We used to call it CEO testing. And we had even tested Obama when he came, and that was like the beginning of that whole process. So now that stopped being donor funded because they're like, okay, guys, you're testing, but your yield is almost negligible. You could test 10,000 people and find 5 positive. So it's not worthwhile. And so for us, the companies, especially public sector, had what are called AIDS control units, and private sector also were looking at HIV in terms of their some of the social things that they're doing, and wellness in their workplaces. And they would ask us for services, and we're like, really, we can't. Our funding, we cannot use it for that. And the discussion became, how do we transition that? How do we start charging for it? And that's how WithMaqC was born. Wellness for Meaningful Action was born. And that was even before 2014. It was like 2012. Because I remember Gladys Wanga, current governor of Homa Bay, was the lead of that. She loved it. So we continued with it and kept building it up. So now we're looking at how do we keep building it. So we had the WithMaqC Workplace Wellness, and the Training Institute, we also transitioned it from where it's donor funded to people paying for themselves. So those all fell under that mandate. So eventually now, it was running under the NGO, but then we realized because of the model is different, and even psychologically, you have to change things. So we registered a separate entity, a company limited by guarantee. So it's a private company that is now managing that business. LVCT Group. So it's now managing those businesses, and it has grown to include the clinic. Also transitioned from being donor funded to now self-funded. So people pay for it to come and receive all health services, but we still continue to provide services to the HIV positive clients that we had.
Funded.
That's not funded.
Not funded, okay.
But we still receive the free ARVs and free, some of the lab tests are free in terms of you can send to Kemri. So those services that are funded, we don't charge, but we charge a consultation fee. It's very minimal, really. So that the patients can keep coming because they trusted us. We've been running the clinic for like 20 years. And so we've continued that, but opened it up to other people. So we have the clinic, we have what is called WithMaqC counseling. With time, we also, especially with COVID, we discovered that our strength is in counseling. We're one of the organizations, the largest pool of counselors in the country. And how do we harness that? So we started mental health counseling. And so we started the WithMaqC counseling where people can pay because it's also not funded. And these same corporates, they needed counseling services for individuals or group, like people can come and have group therapy. And for COVID, it was very critical. You would find a workplace where someone died. The manager just died of COVID, and people are so traumatized. And a lot of suicide cases started coming up. You saw these people who would throw themselves out the window. So we saw that as an opportunity to provide support to those companies and wellness to their staff. Either both group therapy and individual. So we've built the WithMaqC counseling from that, and we're able to provide services across many parts of the country. We have Nairobi, Kisumu, Mombasa, Nakuru even, and wherever people are, we can even go to them, especially if it's a crisis. Like we've had some suicidal cases that we've gone out to. So we have, I've said the clinic, the counseling, the training institute, and some consultancy services that we do for companies. For again, you want to establish workplace wellness programs, etc. Trainings, it's on HIV, it's on mental health, it's on gender-based violence. Safeguarding has come up as a big deal that companies really need to have that.
A lot, yeah.
So we provide safeguarding services or training to companies, to corporates, to different individuals.
Is there someone running that now, or is it integrated into like people's KPIs?
No, there are people now who are hired just for that. And we actually even established paid from that. And we established a separate board for it. So now it's a completely separate entity, but belongs to LVCT because its goal is not for us to enjoy the profit as individuals, but it's really going back to the institution.
So it's a social enterprise.
It's a social enterprise.
You've been able to document it? Like you do with other, all these other programs?
Our weakness. Sometimes it's just exactly that kind of documentation. But currently we're working with a team that's helping us with the business strategy and communication to be able to really separate it. And the biggest challenge, and this is any advice to anyone in the NGO planning to do that, is it's hard to separate. Very hard to separate from the financials. It's hard to separate staff. Because some of the staff came from NGO to that section, and they still struggle and think like NGO thinkers. So managing cost and expenses, because the NGO financial system is that you must spend the money. In private, you have to save money.
The idea is minimize cost,
minimize cost.
Profits,
exactly, and it's exact opposite. So that is
it calls for someone from like a business world to come in with that,
And the other challenge is that, unfortunately, the business world, you may not pay NGO level salaries, especially for service delivery. So that sometimes creates a clash. Yes, those are the lessons we've been learning. We shall document it.
No, it's important. Again, now back to around 2018, 2019 is when you have run. What's your highlight as programs director?
No, I don't know. I've never thought about it that way. I did grow the portfolio a lot.
Significantly.
Yes,
both
I did.
Number of staff, amount, significance,
and the range of programs. For sure.
No,
that's when we got the large CDC grants and were able to deliver them very well.
So upon exit of, had you seen yourself becoming the ED?
It initially when Duko left, I didn't see myself as ED. I felt like I'm not ready, so I didn't even bother to try. And I think it was a good decision because then I hadn't even done my MBA, etc. All those things would have suffered. So now when the next director, Wanjiru, left, I was like, yes, now I'm ready. I've been here for 10 years. Actually, I had been there for 10 years and I was bored. I was now bored.
With time.
Yes, I'd spent a lot of time doing those programs. I knew them.
There's also what we call the law of diminishing returns.
Yes.
You sort of like, you know how this cycle goes, this one. Like you can wake up and fix it, go back to bed.
Yes.
All right, I see.
That boredom and also fatigue of implementing PEPFAR programs. If you talk to anyone who's implemented PEPFAR programs worldwide,
the demand.
The story is the same. Yes, the demands are crazy. The data that is required, the instant results that are required.
Is there like an advocacy that's, I mean, as you say, if you talk to anyone in the world, the story is the same around CDC funding. There's been lately a huge advocacy movement rising about what donors should do, what donors should not do, what donors should expect, what donors should not expect. We're having a conversation with someone who said, guys, if you're going to expect that I send a report after 3 months, I don't want your funding. I don't, because that's not practical because of the issues we are dealing with. And again, because of that fatigue. Have you been involved in such, decolonizing philanthropy and conversations of that nature?
To a very small extent, So occasionally I've interacted with different people and made it clear our position in terms of two things. One is this whole localization agenda, which of course we truly support. So one of the strengths of the two directors we had is that we were clear from when I joined 2008, even 2010, that funding is going to go to local. So how do we prepare ourselves for it? And so everything we're doing was making sure that we do such high quality work. We position ourselves that when funding comes to locals, there is no question that you have an organization ready to handle it. So our systems, our processes have to be really good, really solid. And no one should ever question that LVCT doesn't have capacity to do it. So that's what we've been doing all these years, and we continue to. So, but in that whole phase, so localization happened and funding was made available to local organizations. So for example, both CDC and USAID, who have the largest funding in the country, put out calls and said only local organizations can apply. So that is how we got, we already had some 2 CDC funding, but it was limited to prevention. So now we got bigger grants, which were comprehensive, the whole HIV program area for counties. So right now we're managing a project called Vukisha 95 in Homa Bay and Kisii. It's one of the largest grants for CDC. We have Central.
The aim for that being to move 1990 to 95, 95,
yes,
95. Okay.
Yes. Then we have a project in Central we call the BT, which is now for Kiambu, Muranga, Nyeri and Kirinyaga to do the same thing, the full range of HIV services. Make sure you deliver them. We achieve 1990, you achieve prevention targets.
I'm curious about this one that you just mentioned. Why Central? It wasn't
it's not
ever...
us.
It's
CDC and funder directed. So, but we had been working in Kiambu before.
Although, I mean, in Central, as opposed to like other counties, the infection rates and others was not as bad unless
no, so they're called middle tier. They're the mid-tier counties. While the Homa Bay is higher, the highest level. And then we have USAID funded project at the coast. So that's Mombasa, Kilifi, Kwale, and Taita Taveta. Again, it's a mix of high and mid-tier counties. And we also have a fund from CDC to support all the Kenya prisons services to offer HIV and TB services.
The prisons program was always one of the active ones as well.
Yes, and we did prisons programming before without CDC funding before 2010. So when this call came out, this was other resources, So on a small scale, going to do HIV testing and whatever. And we had a good relationship with the prisons. So when this funding came in 2020, we just went in. And in fact, that was one of the projects which, to me, we've demonstrated LVCT's strength as understanding how government works and getting things done. And being very respectful of the system. Disciplined forces are very complex. And you have to follow protocol, hierarchy, and all that. And so when we went in, they were very clear. You cannot come and tell us what to do. We don't trust partners, all those things. And I was very clear together with the project director that first, we're here to listen and understand what you guys are doing. Secondly, we will work together. We will co-create, we will co-implement. And that's exactly what we did. And the results started coming in. After an initial struggle, because it started during COVID, and all the prisons had been locked down, and they had refused anyone to go in or go out. So even achieving targets was difficult. But the more we worked with them, the more they trusted that actually what we said is what we truly practice. Yes, that we are co-creating with you, we are working with you on your terms, and we meet halfway, of course, understanding what the donor wants. And through that, we've been able to really improve HIV indicators, TB screening, and making sure it's done. COVID, we supported a lot on that. Things like cervical cancer screening. So our indicators are very good. And it's also the one program run by US government through CDC that has fully transitioned from being partner driven and us having people that we have hired, staff that we've hired to implement, to being entirely Kenya Prison Services
taken up by the
they employed people. So we found this, we found and we continue to advocate with them to hire more health workers. And when they come, we train them, they take up the services. So we pulled out the ones we had hired because also the funding really declined. So they've taken up the services. They're the ones who do the supervision. So we twin them, our team and their team, and they do it together. So it's a really good model, and we're excited about it. And so, as I said, that's one of those ones that
that's nice.
We really have to demonstrate.
Beautiful. Now, but as Lilian at the time, all this time I just want to walk through your family alongside so that we don't leave your family behind in the story. By the time you're coming to pick up the role of executive director, how is your family at the time? How many are they? Are they in school?
Yeah, so I have 2 kids. Yeah, so I'm married with 2 kids. My daughter is 17 and my son is 13.
Jesus.
My son was born when I was working in LVCT, and it was...
You are a new employee?
No. I had worked for 2 years. It was when I was being promoted to Director of Services.
Right.
Actually, what happened is I was going on maternity leave. My second born. Yeah. I was going on maternity leave when I had to take up the role of Director of Services. So I went on a quasi maternity where I had to review. We were closing out a big project. I had to review things. So I actually felt sad for myself. And the poor boy. So at some point, I said, okay, I can't do all this. So we had to negotiate with the director. I can do this, you do this. I will support with this. Because it was a crisis. The director was leaving and I was coming in and I'm the one who knew the project. So the other people could do a bit, but I had to do quite a bit. So anyway, that is an LVCT baby. He's now 13. Yeah. If you ask them about me and my job, they'll say they would rather I quit so that I can stay at home more. They find that I'm very busy, come home late, travel a lot. So they feel like I'm not there for them. So I have been trying to be deliberate about being present. And when I'm there, to be present and have fun, interact with them. So I have a very friendly relationship with them. We are friends. That has always been my goal, and I'm happy.
As a mother, though, it's hard to hear that, right? Like to hear, I want you more here.
Oh yeah, it's very difficult, and you actually do feel like, oh gosh, I have to give up some things for them. Actually, in terms of traveling, I'm one of those people who travel when it's essential,
when it's necessary.
Yes, I don't. It's not all trips.
Because then it can be every week.
Yes. So I delegate a lot of that traveling. I will go and come back very quickly just so that I can be home. And I thought it's bad when they're young and that they improve when they get older.
No, it doesn't.
It doesn't.
My son comes home and looks for me. Recently he came and just like he was okay. Then he saw me sitting on the desk. He just jumped, started crying, really cried a bit, and then said, "That's all I needed right now. And I'm happy to find you at desk." Yes. I was like, Jesus.
Yeah, they make you feel bad.
It's hard. I thought like they grow out of it with time, but
that's what I thought. So no, there's we like having you home. Do you have to go to the office? Why can't you work from home? That kind of thing. So I have to be deliberate to balance, but they'll still complain. I'm like, okay, they will always complain. So I have to also find my balance.
Yeah, there's got something to give.
Yes. So that has been tough actually. Yeah.
And but what kind of children are they? Like what does your daughter like? What does your son like?
My daughter enjoys life.
A big spoon, eh?
And she likes to have fun with her friends.
Is she extra? Like, is she a calmer version of you, or a more you're the calmer version?
I'm the calmer version of her. Okay. Yes. So she's very social, and she never thought she was, but she's very social, and people are drawn to her. And she's very friendly, so she likes that. But at the same time, she's also into sciences and math, like me. So I was like, that's what you got me. Yes.
The boy.
And the boy is very calm, and actually is very content staying at home. Although it's staying at home, so he can play with his friends online, the games. So he's very happy to have online relationship with his friends. Then play soccer, which he really likes.
That's cool.
Yeah. So, but generally very calm. Very good friends with the few friends he has. Yes, that he really likes that. Well, my daughter is more of the social butterfly. Yeah.
Your son looks like he'll take on what? AI, robotics and stuff like that.
Know. It's still open.
It's still open.
Yeah, and it's okay. I'm open for them to keep exploring and seeing what they're interested in.
What's one tip you'd give a mom, a working mom?
That I don't know if it's a tip. Okay, my experience is that you will struggle. It's a struggle to balance. Many times you'll feel like you're a failure as a mom, actually. But take heart that they're learning from you as well. They also have to learn things like work ethics and all that stuff. But you have to be deliberate to balance and find time for your kids. So something will have to give, either your social life or you'll tone down your work or your family. So you have to balance out to just make sure you find time. So be deliberate about those nuggets of time, or those little moments that you can really get to spend with the kids and be their friend. We talk a lot with my daughter, and she's able to share with me experiences her friends have and herself. And many of them are jealous about how we talk. We talk like friends. If you hear her, if you hear our conversation, we joke a lot, laugh a lot. And I've been very deliberate to nurture that because many times I've seen how, we work with adolescents and teenagers, and they just want someone to listen to them and not judge them. So you have to maintain a straight face when they start telling you things that you don't want to hear. You cannot be judgmental, but use those as teachable moments to introduce certain things.
Subjects,
Yes. And that's what I've done until sometimes they're like, don't tell us anymore.
It's
don't,
too much.
Don't tell me
I'm
anymore.
shy. I don't want to hear that from you.
Yeah. So it's tough. And you question yourself. And unfortunately, I even read this somewhere. There was an article about how a lot of parents are struggling with teenagers globally. It was in The Guardian. And it said, when babies are born, there's so many groups, support groups, online pages, Facebook, for advising you how to manage as a new mom. There are very few for teenagers. And people don't share their experiences because they're ashamed. That, I'm so ashamed about what my child has done. You don't share it on Facebook or in a group. And yet very many people are going through it. So, and that story came from moms who are now, or parents who are now taking time off. Like, they people take a parental break when kids are born. Now people are taking a teenage break.
Just to be there.
They have to be there until they finish school, till they go to university. Then your work is done. And I was like, okay, I can see that because the demands of teenagers are quite heavy.
And managing home as a mom that is working as much, because home is not just the kids, it's also the house itself, the home, the husband, everything that comes with home. We are super women. What can I say? You have to do it.
You have to do it. And don't beat yourself about it that your home is not perfect, it's not clean, and you don't cook. If you don't like to cook, don't cook. Do what you enjoy to do. Delegate the rest. That is why you can hire help. You can also work with your kids. You can let some things slide. I don't beat myself about perfection in the home.
Have you been lucky to have have you been lucky in the nanny department?
Yes, I've been very lucky. I've always maintained my nannies for long. People leave to get married or something like that. It's only one that I had to let go of. So I've been lucky, but I also told myself, why are you expecting your nanny to be you? They can't be you.
There are help.
Yes, there are help. They're taking this job out of desperation. They could have done something else. Or if they were smarter or whatever, they would have had other opportunities. So don't also expect everything and too much.
Yourself.
Yes, just accept what are your bare minimums that you must deal with. I'm very clear that I want someone who is consistent and loyal. If you said you're coming back on Sunday, you're coming back on Sunday. So that, because I travel and they're the ones who are left there taking care of my kids, I need someone who I know when I'm not there, the kids are comfortable with. We'll cook, okay, we'll take care of my house. Is not a thief, things like that, If you're not perfect at cleaning, we shall discuss and keep trying to improve. But that is not my most essential. My most essential is, are my children safe and well taken care of? That has helped me a lot. Therefore, I don't have very high expectations. Actually, I manage my expectation.
That's good.
And then I don't also cause and shout about everything. It's just making me angry.
It's it can toxify you.
Yes.
Yeah.